Uh, Welcome everyone to today's seminar in the Global Health Rounds. It's my great pleasure to introduce Professor Adrian Wagg. Professor Wagg received his medical degree at the University of London in 1989. He then went on to become a senior lecturer and consultant in geriatric medicine at the University College London for 12 years prior to coming to the University of Alberta in 2010 as a professor of healthy aging in the Department of Medicine. Dr. Wagg also holds the position of professor of continence science at the University of Gothenburg in Sweden. Dr. Wagg has been AHS's medical director for seniors in the Edmonton zone since 2012 and is the co-chair of the International Consultation on Incontinence, which he develops national and international clinical practice guidelines. Prior to this work, he was the General Secretary of the International Continence Society. In his service to the community, Dr. Wagg is now the immediate past president of the Canadian Continence Foundation and participates in numerous other activities promoting health literacy and healthy aging of seniors. So if you're ready, Dr. Wagg, I'm looking forward to your talk.
Thank you very much, and thank you for attending, everyone. I'm going to talk to you about a trial which we conducted in rural Bangladesh, which was around incontinence in older rural Bangladeshi women. And I'm presenting this on behalf of my colleagues and research team who performed the study. So this was a talk of three parts. The first is to talk about the index cluster randomized trial of our exercise intervention delivered by community paramedics to manage incontinence in elderly village women, some of whom are pictured here, which is published in the Lancet Global Health in 2019. Then I'm going to talk about two follow-up studies which address sustainment and sustainability. So GK, my colleague Nicola Cherry, whom some of you may know in preventive medicine, has been working with JK for many years, and this collaboration came to fruition as part of Dr. Phil Baker's schools, which threw people who wouldn't normally work together, and we realized we had a joint interest in things which were of mutual benefit. So GK is an NGO which was registered in 1972 after the War of Independence to serve health in rural villages in Bangladesh. It provides healthcare, hospitals, has a pharmaceutical manufacturing plant and a medical school, and actually gives its own degrees. Its website is here, and it really covers the majority of the country, all apart from one department. You might say, well, why on earth did incontinence become something to consider? So Nicola was involved with a disability survey in GK throughout the women and a needs assessment of 43,000 elderly residents of the villages under the care of GK. And a third of them who are about over 60, and that's defined by their stage of life at the War of Independence, largely because there's no clear birth certification mechanism. 30% of them said they were troubled by incontinence. And intriguingly, 40% of the women also reported depression versus 15% without incontinence. We think that is often related to religious practice and the need to be clean for prayer in a chiefly Muslim population. And this has been reported in a previous work I did with the Bangladeshi community in East London, but also in other societies. So what can you do for incontinence? People will say, well, it's never that important. It's said by many Western authorities to be a lifestyle disease and not to be worth importance. People don't report it. It's taboo, but there are good treatments available. We still have a great awareness problem, even in Western societies. However, the first line treatment for any kind of incontinence is pelvic floor muscle training. The Cochrane reviews, the most recent one here from 2018, showing that pelvic floor muscle training is better than no treatment in reducing incontinence episodes, and it should be the first line treatment regardless of whether you have exertional or stress incontinence, mixed symptoms, or urgency and urgency incontinence. And that works for different mechanisms, which we won't go into at the moment. There are data from an unselected group of older Japanese women that's showing that pelvic floor muscle therapy combined with musculoskeletal and gait exercises are efficacious for reduction of incontinence of any type from older Japanese women. So we wanted to find out if a similar intervention was feasible and effective for older women living in the villages looked after by GK. So the intervention was based upon the work of Kim in the Japanese cohort. 2 60-minute physiotherapist-led group exercise classes, which looked at mobility and pelvic floor muscle therapy, each week for 12 weeks with a brisk 30-minute walk. And that was in addition to the exercise that the women did often to reach various destinations in their daily lives. Women were encouraged to do home exercises on days when there were no classes, and they were encouraged by the village paramedics to continue home exercises for a further 12 weeks. You can see on the right side of the slide the kind of training that the village paramedics, often young girls with the responsibility of the health maintenance of both men and women in the villages, had, and GK had started training its own physiotherapists just prior to the start of the trial. Off-protocol research paramedics led group exercises in weeks 13 to 24, and the intervention lasted 12 weeks altogether. So the preliminary work before the trial involved the development and testing of the exercise intervention in 2 villages and a feasibility trial of the whole procedure in 5. Many of the questionnaires we used had been validated, but not in Bangla, and we engaged in translation and back translation, the psychometric evaluation of the questionnaires used in the study, and gained a focus group and qualitative assessment of the perception and acceptance of the exercise intervention. We thought that women wouldn't want to talk about incontinence, but actually you get a few of them in a room and we couldn't stop them. There's incredible acceptance and very open discussions once men were out of the picture about incontinence and how it affected people's lives and what people did to manage it. So this was our 3-trial intervention. We have we'll show you the primary measure and the means we use to do that in a moment. But this is the pre-post exercise change in urinary frequency and incontinence episodes by village. You see that many women were incontinent at least once or twice a day, and they had frequencies of over 8 times per day. And we saw a statistically significant change in urinary frequency, and in one of the villages in 2 of the villages in urinary incontinence before and after the intervention. So we then went on, having decided that this was indeed feasible. We had the right materials. We selected, according to our power calculation for the cluster randomized trial, 16 pairs of villages. Each pair were in the same upper or the administrative region, and the pair were far enough apart to minimize contagion. Women actually didn't travel that much, but often had family in local villages. There was some cell phone ownership, but it was low, but we wanted to make sure that these were more than 10 kilometers apart. Each woman had to be large enough to have a sufficient number of women aged 60 to 75-year-old with incontinence with similar socioeconomic composition. Each village had health cards for each woman, including age, and the paramedics did regular surveys of the women who were in residence so that we had a good idea of who was there and who might be eligible. One village in the pair was randomly assigned to exercise plus an educational program, and the other to just education. So the education intervention included education about healthy bladders, normal fluid advice, avoidance of constipation, and advice on fruit and vegetable intake. And this is an English translation of some of the cards which were shown by the people delivering the educational component. Treatment of constipation is often used as a lifestyle measure to reduce urinary urgency and urgency incontinence, as well as exertional incontinence. So this was a very simple thing we felt people could do. The education intervention was delivered at baseline during recruitment, and we had village meetings to talk about the study and to recruit women who were then seen individually to give informed consent by means of a thumbprint, at which snacks were delivered to encourage participation and discussion. The educational intervention was reinforced at weeks 4, 8, and 12, and then weeks 16 and 20. This was our primary outcome indicator. This is a bladder diary. We undertook several focus groups and discussions about how best to count urinary frequency and incontinence in women who were often illiterate, and the majority were, but were very numerate. Women counted by recording knots, and this is a means of women wearing a discreet bladder diary around their waist, which could be hidden under their clothes, and they tied a knot. They tied a knot in the yellow ribbon on each day when they recorded going for a pee, and they recorded a knot in the red if they wet themselves by accidents. And this was our end product, and we had a production line of ladies not involved in the trial producing these, and we did that ourselves, and it was found to be feasible and acceptable to women, and we showed that the knot count was responsive and triangulated with another verbal measure of incontinence called the Sandvik Severity Index. So this was our major tool. So in both the exercise and the intervention groups, the women wore this continence diary under their clothing for 3 days, every 4 weeks. They tied a knot in the red ribbon for incontinence, and urinary frequency, a yellow knot. And the research paramedic, these people who had nothing to do with the trial except to collect data intentionally, helped them put it on and remove it and reminded them to use it. So we had some GK staff involved in this, a very integrated team where we were working remotely with the local team to get the trial working and making sure that it ran, and troubleshooting as we encountered any problems. So the village paramedic, this is the young lady with the responsibility of the health of the women, identified and interviewed village women to identify those who were incontinent. The research paramedic, these were trial-related staff, collected the data, helped the women with the diaries, carried out the education intervention, helped the physiotherapists with their classes, and encouraged exercise. Our community physiotherapists trained the women one-on-one in the pelvic floor muscle therapy, and we had an expert specialist physiotherapist from Edmonton who traveled with us to talk about pelvic floor muscle therapy education and how to do these. The physiotherapist then led the exercise classes and some trial classes under the tutelage of Diana, and kept records. And then we had a field monitor who ensured that the logistics were there, that supplies were delivered for the trial, and all information was correctly collected and carried out data coding. So using the family cards, village paramedics identified all women aged between 60 and 75 in each village. All women were interviewed using 3 standard questions about leakage, its impact. And those who were positive to any question were eligible, but excluded if they couldn't walk, if they were felt to be too confused to participate, or had a visible prolapse on perineal inspection. So here are our primary and secondary outcomes. For the primary was the change in the frequency of leakage from the baseline to 24 weeks as measured by our diary. Secondary outcomes were frequency of micturition, the severity of urinary incontinence. This is the Sandvik Severity Index, which is a verbal report of frequency and quantity of leakage at both 3 and 6 months. We used the validated Mbangla CESD questionnaire at 3 and 6 months. The level of distress caused by urinary symptoms as measured by the Urogenital Distress Inventory version 6, a short form, and all of these were pre-selected to be brief and minimally burdensome. And the EQ5D, again validated in continence research, but also in Mbangla, was used to measure a generic quality of life. So we had analysis by intention to treat, and all women who consented and completed the baseline questionnaire and a baseline diary were included in the analysis. We used last observation carried forward to impute for missing values, and only 22 women didn't complete. And this, you can see, is the final press conference to discuss the results of the study, and the august team of investigators talking about the dissemination of the project, which, as you'll see later, hit the national news. So we had 298 women in 16 villages in the exercise classes, and 281 women who took part in the education-only intervention. And there were no differences in baseline between the two arms on mean age, body mass index, or gravidity. The percent poor or very poor on their insurance status, the number of widowed living with a son and daughter, or those with a urine infection at baseline. And we did field microscopy with a hemocytometer to detect pyuria, because we couldn't get a dipstick urinalysis available in Bangladesh. And we treated with antibiotics those people who had significant pyuria and acute urinary tract symptoms until resolution. So we provided all the trial materials. There was one interesting thing that happened, that we clearly were concerned that incontinence was stigmatizing. So we asked that the treatment materials were carried in a bag that the women could carry, which wouldn't have any idea of what was going on, so it would be discreet for them. And when the bags came, they had some Bangla script on them. And we inquired what this was, and we thought, well, it was probably just GK advertising what they were doing, but it said Bangladesh Incontinence Research. So they got scrapped, and then we produced just plain bags. But here's our baseline and 24-week outcomes on our outcome measures. So as you can see, the change in the intervention and the control arms between baseline and 24 weeks. But urinary incontinence at baseline in this group of women was high, with 12 incontinence episodes per day. But at 24 weeks, it reached fewer than 2. And likewise, we can see a change towards improvement in the control group, just the education arm. And this was true for all of our secondary outcomes, that depression got better and quality of life improved. The difference between the intervention and control arm favored the intervention arm. This is the decrease in urinary incontinence episodes over the time of the study. We see a plateauing of the improvement, which was less obvious in the education-only arm. So the dry rate, the absence of incontinence on the final 3-day continence record, reached a median of 41% in the 16 exercise village, and no woman in the education village achieved dryness. And this was an attributable rate of 41%, which we felt was extremely important. We also showed that depression decreased in both groups from baseline to 24 weeks, but there was no statistically significant difference in scores between the two arms. But at 3 months at the end of the physiotherapist classes, the intervention group had a statistically significantly different drop in score. And this may say something about the social engagement. For instead of the brisk 30-minute walk, actually many classes took to music and dancing for the women, which allowed significant exercise, but also provided a social engagement component. And we'll talk a little bit more about that later. Quality of life improved in both groups from baseline to 24 weeks. The exercise group scores were statistically significantly higher than the education-only group. Unfortunately, our subscales of the EQ5D weren't well completed, and this took a bit of translation for women to realize that the thermometer here could be scored anything and didn't have to go along one of the major lines. But actually, only pain or discomfort was better in the exercise group at 24 weeks. And in fact, the only adverse events recorded in the trial were related to initial pain and discomfort as part of the exercise program. Women were able to consent or not to intravaginal examinations to ensure that they could indeed identify their pelvic floor muscles along the trial. And many women did consent for that and were happy to do that in isolation with female physiotherapists or even the paramedics. We offered for those people with symptomatic prolapse the facility to have prolapse repair, and we paid for operative intervention, but no woman with a large prolapse volunteered to undergo operative repair. This was our mean predicted health scale by baseline and 24-week reports between the difference between the education and the exercise group, favoring again the exercise and education intervention over education alone. So the result of the trial was that good evidence that our exercise intervention was more successful than just education in managing urinary incontinence for these rural, poorer women. The intervention resulted in a better perception of health and at 3 months a lower depression score, and that we had a very high rate of completion and no adverse effects. So we were quite pleased. We successfully delivered what could be quite a complex intervention by existing staff within existing facilities as much as we possibly could. And in her editorial, Jean Hay-Smith, writing in The Lancet, said, "For those as excited by the effectiveness of the intervention shown in this setting as I am, then what happened next? Did pelvic floor muscle therapy adherence disappear as it does in other studies? Did the NGO adopt and roll out the intervention in their control villages and elsewhere? Did the effect change with implementation? And what adaptations were needed for widespread implementation?" All very good questions, Jean, and some of which we're in fact able to answer. So we did 2 supplementary studies. Again, this is Dr. Cherry giving her the part of the report at the final Congress. Were they still dry 12 months later? Could we sustain benefit? So was there sustainability? And can the exercise classes, rather being led by our physiotherapists, who are pretty short supply and more complex to train, could the exercise classes be led by our village paramedics? So after the year of the study ended, we wanted to find out, was there any benefit? Were there any efforts to continue the exercises? So what we did an interview with the village paramedics. We wanted to know if group exercises continued after the 6-month intervention, who organised them, how was the intervention received, and was there any difficulty with having a paramedic rather than a physiotherapist-led exercise program? Anecdotally, in the pilot and randomly in the cluster randomized trial, we had some evidence of women themselves convening classes outside the physiotherapist and paramedic encouraged classes, and having small groups doing things on their own. So the interview also covered with participants. We wanted to know about their participation exercises since the end of the trial, whether they continue to do home exercises, and we talked about their report of that, but also asked them to share, see if they had their exercise cards and could follow what they were doing. We wanted to know whether the intervention was acceptable and how it might be made better for the woman who is involved. So we had 6 exercise villages of the 9 out of 12 in total, and 96 women in the main study were part of this, and 80 were recruited for the follow-up. Of the 16 we couldn't find, 5 had died, 5 have moved to relatives elsewhere, 3 couldn't be found at home, and 3 were unable to answer the questions. And this is Dr. Chowdhury, who is the founder of GK, and he fought in the War of Independence, and unfortunately is a widespread government critic, and apparently is under surveillance by government agencies because of his outspoken nature when we got in there, and he was a little outspoken in the press conference. So our follow-up of our 80 women. 35 of the women had continued with their organised classes, and 8 were still attending them. 71 of the women were still doing their exercise at home, and of those women, of all of the 81, 74 showed the home exercise sheet. So we thought that was pretty good, a sustainment of activities involved in the study. If we looked at the dry rates, how had things changed in these 80 women? So at the end of the main study, 56% had no incontinence, at 64% of them were continent at follow-up. Of those people with less than 1 episode of incontinence per day, 43% at main study and 43% at follow-up. And only 1 and 7% had got wetter over the year. So again, we were pretty encouraged by the ability and utility of the intervention to be sustained. This is our Sandvik Severity Index, which looks at frequency and quantity of urine loss. As you can see, the majority of women were not incontinent, and a normally distributed frequency of urine loss. And we see again only 6% of women are having a large amount of urinary loss. So what was the stability of the end of study to 12-month study? So those people who are dry at the end of the study and follow-up were 35% or 28 women. Wet at end of study but dry at follow-up, 29% of women. Dry and going to wet, 21, and wet at end of study and follow-up, 15%. And clearly, given the sampling frame, there will be some shifting between categories. So some changes, but overall, 63% of our women were dry at follow-up. Exercises since the main study. In 3 of the 6 villages, the village paramedics continued group classes, and 2 of those women classes continued 12 months after the main study. The women who attended the classes did home exercises were much more likely to be dry. So those people who did no exercise now, 1/3 of them were dry, but people who did the exercises, more than 70% were dry. And this was same for those both wet and dry at the main study. So sustainable results were dependent upon continuing to do and engage with the exercises themselves. If you looked at depression, the biggest improvement in depression scores were from baseline to 3 months. But you can see a sustainment of depression score at month 6 and at month 12. And was depression related to dryness? As you remember at the start, we said that people who are incontinent were more likely to be depressed, 40% versus 15%. But then the improvement in depression was confined to those who either remained or became dry at some point. You can see here that the people who are dry at the end of the study and at follow-up had improvements in depression score, and those people who were wet had no improvement whatsoever. So again, there is this link between the impact of incontinence on depressive symptoms in these rural Bangladeshi older ladies. So what did they say? The women say about how the program could be made better. This is our head of medical services for GK explaining how the 3-day belt can be made into and used for our women at our training camps. And we had training camps for both the village paramedics and the physiotherapists and our research staff. So village women wanted to be able to tell others about the benefits, and here's a descriptive quote. You know, they were actually quite didactic and autocratic about how they wanted to do this. So we'll go to the other village women and tell them about the exercise class and tell them how we cure them, so they will agree to join the program. Village women wanted other women to join, so they said, you know, arrange snacks, get the meetings going, describe the benefit, and they will agree to work with you. And this is a picture of some of our village paramedics during one of our training camps. Village women were convinced of the benefits of the exercise and advice. The things that you applied for exercises, they should do for other villages women, and advise other women to exercise regularly and take enough water and vegetables. What did the paramedics say? Get GK to train all of their paramedics so they can continue. They told us that GK has done a good job for village women, and that the village women feel happy because they could be cured. And the paramedics, what did they say? They said the neighbor and relative of the woman told us that this is a very effective exercise. It was better if the exercise have extended another month and extend to other villages. And GK always does something good for poor and vulnerable people. Were there difficulties? We were debating in some of the follow-up studies whether we should carry on with the 3-day belt and any questionnaires at all. The paramedics were very convinced that these were ways of helping women to take the thing seriously, and that if there were no questionnaires and no interviews, the women would not do so. And if you can't count it, you can't measure it, you won't know if you are better. And the women, the paramedics felt that these were very useful things to aid the adherence and compliance of the women with the program. So until now, there were no trials of this nature in countries like Bangladesh. There were virtually no data really in Western countries about long-term adherence. As Jean Hay-Smith said in her editorial, adherence falls, and there are some data suggest that adherence falls within 3 to 6 weeks. So we were rightly encouraged by these results. So what about exercise group therapy beyond the trial? We showed that a group exercise was feasible and effective to manage urinary incontinence in elderly women. And we've seen that improvements in continence and depression can be maintained up to a year after the cessation of the formal trial. So we want to know, could we improve the lives of incontinent women within GK and in other villages in Bangladesh and beyond? So this is part of a scale up and spread project. So the original trial, as you heard, used community physiotherapists, and they were in short supply even within GK, and they had many calls on their time, and we felt guilty sometimes for diverting them to the study from their usual practices, often teaching other physiotherapists. So we wanted to know, could we roll out the program using the village paramedics? They were trained by the physiotherapists, but then with the paramedics running the exercise groups and the pelvic floor muscle therapy. And as we said, in the main trial, the research paramedics ran groups in every exercise village in weeks 13 to 24, and this replaced the research paramedics with the village paramedics. So we tried, we rolled this out in 20 villages. Priority was given to the 16 villages in the cluster randomized trial who were in the education arm only, and we added in 4 who were unexposed. So a village paramedic from each village was chosen to be trained and to lead an exercise group for 6 months. And in the main study, she identified every woman aged 60 to 75 in her village. She found out who was incontinent using the same criteria as before. And women were included along the same basis. We informally evaluated the study by using the Sandvik scale before the study and at 6 months of group exercise. So that's the severity of incontinence in terms of frequency and quantity of urine loss. We recorded class attendance and obtained feedback from the physiotherapists, the village paramedics, and the village women who participated. This is the timeline. Back in 2018, we had a training camp. We started the exercise. We had a 6-month program, and then the end. In January 2019, we had a village paramedic feedback and training camp, and then mid-March 2019, repeat Sandvik questions. So in practice, the start of exercise group was delayed in some of the villages, with the earliest just taking off in November 2018 and the last in January 2019. So the training camps were conducted by physiotherapists who'd taken part in the main study. We provided exactly the same exercise protocol of 2 one-hour exercise sessions per week, plus the home exercises, but for 24 weeks. The physiotherapists also visited the villages to ensure that the protocol was being followed, and we had field monitors who had previously been involved in the cluster randomized trial who checked the data which were collected. So the results, we had 2165 women, of whom 700 were eligible, and 33% were eligible compared to 32% in the main study. We recruited 316 women, and there was a maximum that the classes could reasonably hold around 22 and 25. But we had some larger in the main study, so we didn't limit it, but largely it was 13 to 21 women in each class. All women completed their Sandvik severity scale before starting the first exercise class. And these are the baseline results from the 20 villages. As you can see, that 50% of the women were incontinent every day or night, and 42% of them had more than small splashes. So quite a severe group of women with incontinence. This was their so more than 50% were severe, and with a further 30% being mild. This is our class attendance from the first 4 months. You see there's an initial drop off by week 3 from 90% to 70%, but by and large then pretty stable across the duration of the study for the first 4 months, with around 70% attendance. As you can see that in the first 3 months, the attendance was very much the same as in the same study, with an average of 6.4 to 6.2 out of 8 classes in the main study and in the rollout. In the 20 village rollout, with those 316 incontinent women, we recorded improvement in both severity and total continence on the Sandvik questionnaire, and it was related to the total number of sessions attended, with an odds ratio of 1.09. And as rollout, 38% achieved continence, which we felt was comparable to the 43% in our cluster randomized trial. So 38% of the women, of whom 50% were severe, were dry at the end of the study. And this was published in Neurology and Urodynamics last year, answering some of those questions posed by Jean Haysmith in her editorial in The Lancet. So what have we learned? The intervention, as planned, was feasible within available resources using village paramedics. It was sustainable, but of course women need to sustain the exercises to main benefit. And something that's been remarked upon when we've presented this international congress is the social benefits. The social benefit and the coherence in the women was should not be minimized and shouldn't be underestimated. The women had, many of them were described via interpreter, a great time. They felt that the fact that someone was paying attention to the problem was of great value, that probably improved the adherence. They found even provision of training camps and education with snacks encouraged participation. One of the main barriers to recruitment was having a male relative who forbade participation, and kicking out the men from the educational seminars was bizarre. Well, interestingly, felt to be of great value by the women, which then encouraged participation and being very open in terms of the impact of their incontinence and admitting that they dealt with that. So the next question, of course, is what potential do educational and exercise interventions like this, which can be delivered by local people, has for Canada's remote communities? And this is something which we would like to go along and explore as time goes on. And this was the national news for the Bangladeshi English National News Network, talking about the health research on aged women. So we got quite a lot of publicity and have been contacted by numerous agencies working in Bangladesh with whom we have shared our materials, and the materials are all available on the GK website for download and use by local staff from other NGOs. So this is the whole team of local and international researchers who were involved with the trial during its dissemination seminar, with the physiotherapists, the research staff, and some of the village paramedics who turned out to a policymaker and politician attended Congress a year after the study ended.